Hey everyone, I am Dr. Shoham Mukherjee and welcome back to the channel. If you're running short on time and you need to revise pathology super quickly, you are in the right place. In this video, we are going to cover all the high yield topics in pathology in just 5 concise pages, designed specifically for the last minute revision. Whether you are preparing for NEET PG or FMG and you need a last minute quick revision, this rapid revision will help you boost your score and maximize retention with minimal time. So grab a pen, get the PDF from the link given in the comment box, and let's get started with this ultra efficient revision sprint. Also, you can join my Telegram study preparation group. The link for that is also given in the comment box. Don't forget to like, share, and subscribe for more exam focused revision videos. So let's get started. So we'll start with general pathology, and these are very high yield points. You need to remember each of the points, okay? So the most common cause of cell injury is hypoxia. The most common cause of hypoxia is ischemia. Most sensitive cell to any injury is the neuron, and the time is 2 minutes. And after that, the cardiac myocytes are 20 minutes, okay? The most resistant cell to any injury is the fibroblast. Hypertrophy, what is hypertrophy? It is the increase in the cell size. Examples of physiological hypertrophy are pregnant uterus, skeletal muscles in the body, builders. And examples of pathological hypertrophy is left ventricular hypertrophy. What is hyperplasia? It is increase in the cell number, where the cell number only increases, okay, not the cell size, and this never increases in the skeletal and cardiac muscles. What is the example of physiological hyperplasia? It is found in pregnant uterus and breast, in the puberty in the uterus and breast, and we can find pathological hyperplasia in the endometrium and benign prostatic hyperplasia BPH. What is metaplasia? Metaplasia is the benign and reversible change from one cell type to another cell type. Both are normal, okay? From one normal cell type to another normal cell type. And the most common, it is found in the lungs, where there is change from columnar to squamous epithelium, and in Barrett's esophagus, where we can find there is change from squamous to columnar epithelium. Also, in myositis ossificans, there is change from muscle to bone. What is atrophy? It is decrease in the cell size and cell number. Physiological atrophy is found in thymus and notochord, and pathological is found in malnutrition and atrophy of disuse. Disuse means which we are not using, that organ will undergo atrophy. Now we'll understand the differences between reversible cell injury and irreversible cell injury. So in reversible cell injury, there is damage to the sodium potassium pump. In irreversible, there is damage to the calcium magnesium pump. In reversible cell injury, the first microscopic finding will be cellular swelling, the hydropic change. Due to hydropic change, there will be cellular swelling. There will be loss of microvilli. Cytoplasmic blebs will be formed. There will be endoplasmic reticulum swelling, detached ribosomes, and myelin figures are few in number. There is also clumping of nuclear chromatin. And in irreversible cell injury, we will find flocculent amorphous mitochondrial densities, swelling of lysosome, plasma membrane damage, and there will be a lot of myelin figures. We will find pycnosis, karyorrhexis, and karyolysis. In necrosis, it's always pathological, and it affects a group of cells, not a single cell. It will affect a group of cells. The cell size gets increased. There will be smear pattern on gel electrophoresis. Plasma membrane disrupts, and there will be inflammation. In apoptosis, it's more physiological than pathological. It will affect a single cell. In necrosis, it was affecting a group of cells. Here, cell size was increasing, but in apoptosis, cell size will decrease. We will find step ladder pattern on gel electrophoresis, and plasma membrane here is intact. In necrosis, it was disrupting. Therefore, there was inflammation, but in apoptosis, there is no inflammation. What are the pro-apoptotic molecules? It is BAX, BCLXX. Anti-apoptotic are the BCL2, BCLXL, and apoptotic are the BEAM, BEAD, BAD, POMA, and NOXA. So necrosis can be of these following types. Coagulative necrosis is found in the solid organs. Liquefactive or qualicoative necrosis is found in brain and abscess, solid organs like the kidney. Okay, caseous necrosis is found in TB, syphilis, fat necrosis in the breast, omentum, pancreas, and fibrinoid necrosis in the vasculitis and malignant hypertension. Here is the image of the coagulative necrosis, which is found in the kidney. This is liquefactive necrosis of the brain. Here it is caseous necrosis, and this is fat necrosis of the breast. Okay, here coming to here, the most dangerous free radical is the hydroxyl radical, and lipofuscin or lipochrome is a wear and tear pigment. What is telomerase? Telomerase maintains the telomere length. It is present in GST. The mnemonic is GST. Telomerase is present in germ cell, stem cell, and tumor cell. What is virtuous triad? It includes endothelial injury, abnormal blood flow, and hypercoagulability. Now moving on to our next topic, which is inflammation. So acute inflammation we will find neutrophils. In chronic inflammation we will find macrophages and lymphocytes. Opsonins are the proteins that bind to foreign particles like bacteria and viruses and make them more susceptible to phagocytosis by immune cells like macrophages and neutrophils. The examples are antibodies like immunoglobulins, C3b, CRP, and fibrinogen. For the vascular changes, we will notice there can be vasodilation due to histamine, vascular permeability is the hallmark feature, and stasis. For cellular changes, we will notice margination, rolling adhesion, diapedesis, and chemotaxis. These are the macrophages example in kidney. There are mesangial cells, the kidney cells, liver, Kupffer cells, brain, microglia, and Gitter cells, bone, osteoclast, spleen, littoral cells, and placenta, Hofbauer cells. Granuloma, caseating granuloma is found in the TB, hard or naked. Non-caseating granuloma is found in sarcoidosis. Gumma, it is found in syphilis. Stellate granuloma is found in cat scratch disease, and donut granuloma is found in Q fever. All the points you have to remember. All are very, very high yielding points. Next topic is immunity. So the major histocompatibility complex or MHC or human leukocyte complex or HLA complex is located on chromosome, and NK cells are expressed. So CD16 and CD56, NK cells are the viral infected cells and the cancer cells. NK cells does not kill any cell which is having MHC1. Which cells are the main cells for graft rejection are the T cells. So graft rejection based on the duration, if the graft is rejected within minutes to hours, it is known as hyperacute graft rejection, and it is a type 2 hypersensitivity reaction. Acute is less than 6 months and it is more type 2 than type 4, while as chronic is more than 6 months and it is a type 4 hypersensitivity reaction. So type 1 hypersensitivity reaction is the immediate and it occurs due to anaphylactic. What is the mechanism? It is Ig mediated. Mast cell degranulation occurs. There is histamine release and the onset is rapid within minutes. What are the examples? Anaphylaxis, example penicillin allergy, bee sting, allergic rhinitis, asthma, urticaria due to hives, and food allergies. Type 2 is cytotoxic hypersensitivity. The mechanism is IgG or IgM antibodies will bind to the cell surface antigens and it will activate the complement or antibody dependent cellular cytotoxicity. So this is cytotoxic hypersensitivity. The onset is hours to days. What are the examples? Examples are hemolytic anemia, Goodpasture syndrome, rheumatic fever, blood transfusion reactions, myasthenia gravis, and Graves' disease. Type 3 is the immune complex mediated hypersensitivity. What is the mechanism here? The antigen antibody complex will deposit in the tissues and it will activate the complement which will lead to inflammation. The onset is hours to days. What are the examples? SLE, post-streptococcal glomerulonephritis, serum sickness, Arthur's reaction, and rheumatoid arthritis. Type 4 delayed type, and it is cell mediated hypersensitivity. Mechanism is T cell mediated. There is no antibodies, so cytokine will release and activate the macrophage. The onset is 48 to 72 hours. What are the examples? Tuberculin skin test, contact dermatitis, multiple sclerosis, and type 1 diabetes mellitus. So here is a mnemonic for the hypersensitivity reactions, which you can call it as ACID, ACID, type 1A, type 2C, type 3I, and type 4D. It is the mechanism which is representing the mnemonic. So A for anaphylactic. So type 1 is anaphylactic. Examples are allergy, asthma, anaphylaxis. Type 2 is due to cytotoxic mediated. Examples are hemolytic anemia. Type 3 is immune complex. I for immune complex, and immune complex example SLE. And type 4 is D for delayed. Delayed example contact dermatitis. So this is the mnemonic which will help you recall in the exam hall. What is amyloidosis? Amyloidosis is the extracellular deposition of misfolded protein fibrils, amyloid, in various organs and tissues which will impair their function. Now coming to the types, the precursor protein and the conditions. So AL is the primary type. AL is for the light chain immunoglobulin, and the conditions we can find it in multiple myeloma. AA is the secondary variety. The precursor protein is serum amyloid A, and it can be found in chronic inflammations like inflammatory bowel disease. ATTR, the precursor protein is transthyretin, and it can be found in cardiac amyloidosis. AB, it contains the amyloid beta protein, and it can be found in Alzheimer's disease. And A beta to M, it is different from A beta. Okay, A beta to M is found in dialysis mediated. The precursor protein here is beta 2 microglobulin, and it is found in long term hemodialysis patient. This is very, very important. Long term hemodialysis patient, which amyloid protein we will find? We will find beta 2 microglobulin, and the type is A beta 2 M. What is the most common site of amyloidosis? It is the kidney. Best diagnosis method, rectal biopsy. Congo red stain is ordinary light will give salmon pink color. Congo red stain in polarized light will give apple green by refringence. And spleen in amyloidosis will give a lordosis or sago spleen. Now coming to neoplasia. So neoplasia, the hallmark of malignancy is anaplasia, surest sign is metastasis. Normal tissue at abnormal site, it is called choriostoma. Abnormal tissue at normal site, most common site is lungs, it is known as hamartoma. RB gene at 13q14, it is the governor of genome, and guardian of genome is the P53 gene at 17p. Now coming to the various oncogenes and their mutations. So this you have to remember, this is again very important. Questions can come from here. PDGF, this oncogene mutation, it will result in, it is found in astrocytoma, FGF in fibrosarcoma or osteosarcoma, AGF in hepatocellular carcinoma, PDGFR in glioma, EGFR1 in adenocarcinoma of lungs, EGFR2 in breast carcinoma, RET, Men's syndrome, KIT in GIST, gastrointestinal stromal tumor, ALK in adenocarcinoma of lungs. RAS is the most common oncogene which is mutated in humans. It is of KHN and it is found in colon cancer. ABL in CML, MYC is of three types, C, N, and L. C is found in Burkitt's lymphoma, N in neuroblastoma, and L in lung cancer. Cyclin D1, it is found in mantle zone lymphoma. Now coming to the tumor suppressor genes, their location and the mutation. So P53, location on 17p, Lee-Fraumeni syndrome, RB gene, location 13q, mutation retinoblastoma. NF1, location 17q, mutation neurofibromatosis. NF2, location 22q, schwannoma. BRCA1, 17q, breast cancer. BRCA2, 13q, breast cancer. Wilms tumor 1, 2, 11q and 11p, it will cause Wilms tumor. And BHL, location 3p, mutation RCC. What is the stain for epithelial? We are giving cytokeratin. For mesenchymal, we are giving vimentin. Muscle desmin. Melanoma chondroma and liposa S100 and HMB45. Neuroendocrine synaptophysin, chromogramin, and CD99 is for Ewing's sarcoma. Coming to the various tumor markers, calcitonin is found in medullary carcinoma of thyroid. Alpha fetoprotein, this question has come in the January exam also, January FMGE exam. Alpha fetoprotein in hepatocellular carcinoma and yolk sac tumor. Beta HCG, germ cell tumor. PSA, prostate specific antigen, prostate cancer. Catecholamine in pheochromocytoma. CEA, colon and pancreatic cancer. CA 72.4, stomach cancer. CA 19.9, colon and pancreatic cancer. CA 15.3, breast cancer. CA 125, ovarian cancer. So everything on this page is very, very important. Coming to the cell cycle, so radio-resistant phase, radio-sensitive phase. So here the phase is G1S, radio-resistant phase, and radio-sensitive phase is G2M. Tissue, which is radio-resistant, is nervous tissue, radio-sensitive is bone marrow. Cell is platelet for radio-resistant, and radio-sensitive cell is lymphocyte. Organ, which is radio-resistant, is vagina. Organ, which is radio-sensitive, is gonads. And in gonads, testes are more sensitive than ovary. Now coming to our topic of genetics. So first let me tell you that I have made a separate video. It's an old video. You can find it in my playlist, rapid revision playlist. You can find it that there is a video for pedigree. So pedigree video, how to identify autosomal dominant, autosomal recessive from the pedigree chart, which it may come in the exam, you can find from that video. It's very easily explained there. You can watch that from that video. And normal genetics, the theory portion is given here. Okay. What is codominance? Both the alleles are expressed in heterozygous test. Example, blood grouping or HLA or MHC genes. Sickle cell anemia, we can find missense mutation, and beta thalassemia, we will find nonsense mutation. Now, what are the autosomal dominant diseases? So you can understand by this mnemonic, my family has pretty valuable autosomal dominant genes. For autosomal dominant, my family has pretty valuable autosomal dominant genes. So all the first letter, M for F, H, like that you have to take. M for Marfan syndrome, familial hypercholesteremia. So I am not repeating, okay? Just study the diseases from here. So if in the question, if any disease is asked and asked like what type of inheritance is this, you can answer it properly. So if you understand this mnemonic, you can remember these diseases. Again, autosomal recessive is by the mnemonic A, B, C, D, E, F, G, H. A for alkaptonuria, B for beta and alpha thalassemia, C for cystic fibrosis, like that. You have to remember this same. XLD, X-linked dominant, fragile royal heritage affects innocent girls. So FRHAI, by that first letter is fragile. So fragile X syndrome, R for Rett syndrome, like this you have to remember. And X-linked recessive, B wise, fool's gold, hate, silly, hope. By this mnemonic you can remember the X-linked recessive. You can remember the most important diseases which are very much repeated in the PYQ. You can check in the PYQs of FMGE and PG. Okay, and you can remember those specific diseases from here. Genomic imprinting or silencing of a gene. So in paternal deletion of the SNP gene, we will find it will result in Prader-Willi syndrome. Maternal deletion of UBA3A gene, it will result in Angelman syndrome. Mitochondrial, it was repeated in the FMG Jan exam. Mitochondrial inheritance or maternal inheritance. So it is found in Miller's, the most common nerve syndrome, Leber's optic neuropathy, and Pearson's disease. Huntington's disease, we will find CAG repeats. Friedreich ataxia, we will find GAA repeats. Fragile X syndrome, we will find CGG repeats. And the second most common of mental retardation. First one is Down syndrome. Okay. In Fragile X syndrome, there is FMR1 gene mutation. There can be macroarchidism, and these are the clinical features. We can remember this by the mnemonic of Marfan. Marfan syndrome you have studied, right? So these are the mnemonics of Fragile X syndrome. M for MVP, mitral regurgitation. A for aortic aneurysm. R for retinal detachment. F for fibrillin 1 gene mutation. A for arachnodactyly. N for negative nitroprusside test, 9 feet tall height. Down syndrome, trisomy 21. Patau syndrome, trisomy 13. Edwards syndrome, trisomy 18. DiGeorge syndrome, catch 20. From your medicine, you can study the what are the features, what are the clinical features. In your pediatrics also, in your medicine also, you have to study this. Now coming to the hematology, so anemia, microcytic anemia is when it is less than 80 FL. The examples of microcytic anemia are, you can remember this by the mnemonic of SITAL, SITAL, SITAL. So S for sideroblastic anemia, iron deficiency anemia, T for thalassemia, A for anemia of chronic disease, and L for lead poisoning. Macrocytic, if it is more than 100, the examples you can remember by the name MDH. M for myelodysplastic syndrome, megaloblastic anemia, D for disease of the liver, H for hypothyroidism. Iron deficiency anemia, only TIBC, total iron binding capacity, will increase, rest all the parameters will decrease. In sideroblastic anemia, it is the opposite of iron deficiency anemia. TIBC will decrease, rest all will increase. Sorry, here it's a correction here. TIBC will decrease, rest all will increase. And anemia of chronic disease, ferritin will increase, rest all will decrease. In sideroblastic anemia, it's actually iron overload anemia, and it is vitamin B6 responsive. Megaloblastic anemia will find hypersegmented neutrophils more than 6 nuclei. There will be macrovalocytes and HJ bodies. In folic acid deficiency, never give folic acid alone, always give with vitamin B12. Hereditary spherocytosis, it is the most common due to ankyrin deficiency and most severe due to spectrin deficiency. G6PD deficiency anemia, both intravascular and extravascular hemolysis, Henge body, white cells, these are the features. Replacement of glutamate by valine on 6th position of beta chain. Sickle cell anemia, it is the most common in adults. Most common in adults, what we will find: microvascular occlusion, hand-foot syndrome, stroke, avascular necrosis of the neck of femur. Most common things in children, what you will find, there will be sequestration, and also autosplenectomy and acute chest syndrome is noticed in sickle cell anemia. Paroxysmal nocturnal hemoglobinuria, it is an acquired condition. It is due to PK gene mutation. CD55-59 will decrease. Pancytopenia with hepatosplenomegaly, investigation of choice, flare flow cytometry, drug of choice, eculizumab. Now coming to leukemia, so the most common leukemia in children is ALL. Blood count, if it is more than 20%, it is acute, and if it is 10 to 19%, it is chronic. Most characteristic feature of AML is our rods. Odds prognosis AML is M0. Most common AML is M2, translocation 821. DIC and our rods are found in M3 variety, translocation 1517. Okay. Gum hyperplasia, M4, M5, translocation 1616. Down syndrome, AML M7 variety, Philadelphia chromosome, translocation 922, and it is found CML more than ALL. Smudge cells or conventional appearance, these images you can find in the group, Telegram group. I have given a image like PDF for all the images where you can find the all subject images. Here you can find all these, okay, pathology images. Smudge cells or conventional appearance in CLL, garden party or college girl appearance or eosinophilia or basophilia in CML. JAK2 mutation in polycythemia vera, and fried egg appearance in hairy cell leukemia. Multiple myeloma is the most common plasma cell disorder. Here we are using the Crab criteria for end organ damage: C for hypercalcemia, R for renal failure, A for anemia, and B for bone lesions, lytic bone lesions. In multiple myeloma, we will find monoclonal spike on serum protein electrophoresis or urine protein electrophoresis. So multiple myeloma is also important from your medicine also. And there are 10% clonal plasma cells in the bone marrow biopsy. Also, we'll find Benz-Jones proteins, which are free light chains in urine. Dutcher, Russell, Flem, Mott cells are also found. Also, notice these images. If you cannot find that in the PDF, you have to search it from Google. Okay, Dutcher cells, Russell cells, Flem cells, and Mott cells. Along with that, search this one: smudge cells, convent gall appearance, and garden party or college gall appearance. Next, coming to lymphoma. So, lymphoma, Hodgkin's lymphoma, it can be of non-classical and classical variety. Non-classical, the classical variety is again divided into these 4 types. Okay, so here you can find the percentage, the red Steinberg cells, what is the shape of the red Steinberg cells. So this is the mixed cell Hodgkin's lymphoma, this is the lymphocytic rich, lymphocytic poor, nodular sclerosing Hodgkin's lymphoma, all this. Okay, full forms if you don't know, this is nodular sclerosing Hodgkin's lymphoma, this is mixed cell, lymphocyte rich and lymphocyte poor. So non-classical is found in 5%, others, these are found, classical variety is found in 95%. This is MCHL is the most common variety in India, and NSHL is the most common in the world. RS, red Steinberg cell, non-classical, it is popcorn, and NSHL, it is lacunar, MCHL, it is mononuclear, LRHL, it is classical, and LPHL, it is pleomorphic. So this is the EBV, and CD15 is absent in non-classical, CD20 is present, 30 is absent, 45 is present. Okay, and that's the opposite in the others. So in all the others, that's the opposite of this, opposite of non-classical in classical. Here you can find various shapes of the red Steinberg cells, the various variants which we have discussed, like the classical variety which we have discussed in the LRHL. This is the classical. This is the mononuclear which we have discussed in the MCHL. Pleomorphic we have discussed in the LPHL. So these are the various varieties, variants. Most common site of extranodal non-Hodgkin's lymphoma is the stomach. Non-Hodgkin's lymphoma, not the Hodgkin. And Stadiski appearance is found in Burkitt's lymphoma. Now moving on to the respiratory system, emphysema is the most common cause is smoking for emphysema, and centriacinar emphysema due to smoking, it is found in the upper lobe, alveoli is spared and most common clinically. Panacinar, base of the lung, this is the pneumonic bulb, base of the lung, alpha-1 antitrypsin deficiency and panacinar. Okay. Most common complication of emphysema is cor pulmonale. We'll find barrel chest and pink puffer face. These are the clinical features of emphysema. Chronic bronchitis, there will be cough with sputum for at least 3 months in more than 2 consecutive years. No clubbing, no hemoptysis, read index will be more than 0.5. Asthma is reversible, 3 Cs are found, Kurtzman spirals, Crayola bodies and Charcot-Leyden crystals. In bronchiectasis, it is associated with Cartagena syndrome. There will be cystic fibrosis, necrotizing infection, Trump track or honeycomb appearance. All the highlighted points, you have to remember it very carefully. Pneumoconiosis, occupational disease. So silicosis is the most common occupational disease found in the upper lobe, increased risk of TB, increased risk of cancer. On X-ray, chest X-ray, we will find eggshell calcification. Asbestosis, increased risk of cancers. Most common is the bronchiogenic cancer. Most specific is mesothelioma. Bicyanosis due to cotton dust. Bagasosis, it is due to sugarcane dust. Lung cancer, squamous cell cancer, most common cancer in India in smokers, and it has a best prognosis. We will find hypercalcemia, it is found more in males than females, and late metastasis occurs. Adenocarcinoma, it is the most common lung cancer globally and it is found in non-smokers. Squamous cell was found in smokers, this is found in non-smokers. It is associated with Pankos tumor, also associated with asbestosis. There is clubbing, there is Trousseau sign, it is more common in females than males. Small cell cancer, it will give a salt and pepper chromatin, basophilic staining. Azoparity effect, we can see worst prognosis, it has more predominant in males, and maximum paraneoplastic syndrome is observed in small cell cancer. Some points about vasculitis. So granulomatous vasculitis, there are temporal arteritis, Takayasu arteritis, Wagner's granulomatosis, Burgess disease, Chuck-Stock syndrome. In temporal arteritis, it is also known as giant cell arteritis. We will find increased ESR, jaw claudication and headache. In Takayasu arteritis, we will find it is a pulseless disease. Kawasaki disease, it is found in less than 5-year-old child with fever 25 days. Henoch-Solim purpura, most common vasculitis in children. IgA associated vasculitis, here platelets are normal, and we will find non-thrombocytopenic purpura. Coming to the heart, so myocardial infarction, what is the first enzyme to increase after myocardial infarction? It is myoglobin. Most important or specific enzyme for making the myocardial infarction diagnosis, it is the TROP-I. In myocardial infarction, LDH1 will be more than LDH2. Okay, here 2 is missed. LDH1 is more than LDH2, but normally LDH2 is more than LDH1. So what happens in myocardial infarction? There is flipping of the original, so it is known as LDH flip. And triphenyl tetrazolium chloride is positive for LDH. Normally intracardiac LDH, it will give color to triphenyl tetrazolam chloride. What color? Brick red color. And if the myocardium infarction is a leaked LDH, it will give a pale or yellow color. If it is intracardiac, brick red color. Earliest change to see in MI, it is the ATP depletion. In biopsy, if it is less than 4 hours, it will give waviness of the fibers. If it is 7 to 14 days, it will show us granulation tissue. And nutmeg liver is a chronic complication of right ventricular failure due to chronic venous obstruction of rheumatic fever, small form friable limb sex endocarditis. It is medium flat verrucous on both cusp of the surface of the cusp. So on both the surface of the cusp there will be medium flat verrucous. Okay. Rheumatic fever will find small form and friable. Infective endocarditis, there are large bulky irregular on valve cusps and it is non-sterile. Also we will find embolization. Embolization is very common in infective endocarditis. Most common primary benign cardiac tumor, it is atrial myxoma. Coming to CNS, most common CNS tumor, if it is benign in adults, it is meningioma. We will find psammoma bodies. In child, it is astrocytoma. We will find Rosenthal fibers. If it is malignant in adults, it is glioblastoma. And we will find pseudopalisading present. In child, it is medulloblastoma. We will find Homer-Wright rosettes and it is the most radiosensitive. Alzheimer's disease, tau protein is present, neurofibrillary tangles are present, flame-shaped, Hirano bodies are present and neurotic plaque of A beta peptide. Coming to liver, stellate or Ito cells present in the space of DJ are responsible for fat, vitamin A metabolism and repair. Mallory bodies are composed of eosinophilic intracytoplasmic inclusions. Most common cause of post-transfusion hepatitis, hepatitis C virus. Most common cause of sporadic cause of hepatitis, hepatitis E virus. Hepatitis having worst prognosis in pregnancy, hepatitis E. Renal pathology, so flea-bitten kidney is seen in malignant hypertension. Most common cause of nephrotic syndrome in children is lipoid nephrosis or minimal change disease. Anti-GBM antibodies are seen in Good-Pasteur syndrome. Diffuse involvement is seen in post-streptococcal glomerulonephritis or PSGN. Subepithelial humps are seen in PSGN. FSGN having worst prognosis is the collapsing variety. Subepithelial spikes with M spike is a feature of membranous. Tram track appearance is found in membranoproliferative. Crescents with epithelial cells plus fibrin plus macrophage are seen in rapidly progressing. Alport syndrome, it includes hereditary nephritis, nerve deafness and eye disorders. Bilateral renal cell cancer may be seen in von Hippel-Lindau disease. Kimmel-Stein-Wilson disease is seen in diabetic nephropathy. Finnish type of nephritic syndrome is due to mutation of nephrin. So difference between nephrotic and nephritic syndrome, urine cast in nephrotic will be fatty cast and in nephritic it will be RBC cast. It will give us a cola or smoky urine. Proteinuria, it is more than 3.5 gram per day in nephrotic and nephritic it is less than 3.5 gram per day. Hematuria may be present or absent, but in nephritic it is always present, therefore RBC casts are seen. Clinical features for nephrotic are generalized edema, periorbital edema and hypertension. In nephritic are hypertension and edema. Diseases for nephrotic syndrome are focal segmental glomerulosclerosis, membranous nephropathy, minimal change disease, amyloidosis and diabetic glomerulonephropathy. For nephritic, it is acute post-streptococcal glomerulonephritis, rapidly progressive glomerulonephritis, Burgett disease, Alport syndrome. Coming to miscellaneous points, okay, it involves all the topics. So the time for hyperacute graft rejection is for minutes to hours. Neurofibromatosis 2 is associated with schwannoma. Good-Pasteur syndrome involves lungs and kidney. Cells which can multiply into any type of cell or epithelium is the totipotent stem cell. Consanguineous marriage leads to most commonly which pattern of genetic disorder? It is AR. Most common cancer metastasizing to brain is lungs. Which type of hepatitis is associated with maximum chances of chronicity? So most chronic, which hepatitis? Hepatitis C. Fulminant hepatitis is seen with hepatitis E. After chemotherapy in a patient with tumor, which of the following serum investigation will show hypocalcemia? And embryonic neural stem cells will give rise to medulloblastoma. Psammoma bodies are found in the mnemonic is PSM. So P for papillary thyroid cancer, papillary renal cancer, serous carcinoma of ovary S, and M for meningioma and pituitary adenoma. Lewy bodies are found in Parkinson's disease. Stain used for lipids. So these are the various example of stains. For lipid we use Sudan black or red oil. For calcification we use von Cosa or algerin red. For amyloid we use Congo red or thioflavin. For glycogen we use carmine, which is the best. For hemosiderin we use pearl stain. Virchow's cell is seen in leprosy. Virchow's sign is seen in Trossier's sign. Also known as Trossier's sign, it is seen in left supraclavicular lymph node enlargement. Virchow's space is found in the brain between sulcus and gyrus. So Virchow's cell, Virchow's sign and Virchow's space. Cat eye syndrome, chromosome number 22 defect. Reticulocytes are stained with brilliant blue. Most common tumor of the heart are the secondaries. Jumping gene is known as transposon. CD4 cells are the MHC2 restricted. CD8 cells are MHC1 restricted. So 4 into 2, 8, 8 into 1, 8. It should be 8, okay? You can remember this by 8. If it is CD4, so 4 into 2 is 8. If it is 8, so it is already 8. Therefore, 8 into 1, MHC1. Beta cell markers are CD19, 20, 21, 23. T cell markers are CD4, 3, 7, 2. Most common mediastinal tumor is lymphoma. Parvovirus B leads to aplastic crisis. Gamma antibodies are seen in portal hypertension and sickle cell anemia. So that's the end to our high yield points of pathology in just 5 pages. I have made ultra rapid revision videos for 11 subjects except pathology. So with like including pathology, there will be 12 subjects. You can watch the other videos in my channel. A separate playlist is made for the rapid revision videos, and I already told pedigree. There is a separate video. You can watch the pedigree video, and if you want the PDF, the link for that is given in the comment box. You can get and go and download the PDF from the link. Also, the link for Telegram channel is given in the comment box. Please download it from there. Please join the Telegram group, and if you have any queries, you can message me on Instagram. This is my Instagram ID. Also, you can put down your feedback, any good, bad, any feedback. Please put down in the comment box. It will help me improve and also provide you more better content. Thank you.